When a new patient presents with follicular lymphoma in the first-line setting, and the most important thing is to stage them. Patients typically are presenting with advanced stage disease, but about 20% of patients with follicular lymphoma will have early stage disease, and that disease is treated differently. We may have options including definitive irradiation, and so when a patient comes to you, that is the first step, is really staging a follicular lymphoma patient. Once you have a patient that is advanced stage and you're not able to offer them radiation, the next step is really to assess the disease burden and the fitness of the patient. And so fitness might be comorbidities, age plays a factor in some respect, but really assessing the fitness of a patient is important in stratifying risk factors. The next is really to assess the disease burden of follicular lymphoma. And so patients can have indolent, slow-growing, and low-volume disease, which would not require urgent therapy. And those patients are best managed initially with active surveillance. If patients typically will present later on their course with more bulky disease, that would be an indication to start treatment, and that may also come with anemias, it may come with B symptoms, and that would be a treatment indication. Historically, we've been using the FLIPI score to assess the risk factors and long-term prognosis of patients with follicular lymphoma. In recent years, the molecular mutation burden has been recognized as a potential solution to improving our prognostication and predictive value of these tools. The M7 FLIPI was developed in a cohort of patients treated with R-CHOP, and then validated subsequently in a cohort of patients treated with RCVP. And in that study, they found that 7 genes that are frequently mutated can help the FLIPI predict a low versus a high-risk disease. In this ASH, this year's ASH, there's been additional studies that have looked at how well M7 FLIPI is predicting patient outcome with newer therapies, either chemo alone or with bendamustine-based therapy. And the M7 FLIPI has not been shown to predict as well as in the R-CHOP. And so currently the M7 FLIPI is more of a continued process and using clinical trials. And I think there's plenty of additional work needed to improve upon our prognostic and predictive value in our risk factors for follicular lymphoma.
The analysis of the M7 FLIPI in the GALLIUM trial is actually quite interesting. So it was intended to be a validation of M7 FLIPI to demonstrate that it has utility in prognosticating outcome in patients with follicular lymphoma. It's interesting in that it did validate the M7 FLIPI in patients receiving RCVP and R-CHOP, but interestingly, it was not prognostic in patients receiving a bendamustine-based chemotherapy. So I think we're in desperate need to find biomarkers that are predictive of outcome in patients with follicular lymphoma, and the M7 FLIPI shows some promise. But just as we'd suspected, biomarkers are likely going to be need to be put in context to the therapy being given, and definitely seeing the results of this trial and broken down by homogeneously treated patients, I think is quite informative that the M7 FLIPI clearly has value in the right context. It's interesting that EZH2 was confirmed as a prognostic marker within the data of the GALLIUM trial, but particularly within patients receiving CHOP or CVP. So for the patients treated with CHOP or CVP, those with an EZH2 mutation actually had a better outcome and longer progression-free survival, but that wasn't seen in patients receiving bendamustine. In fact, there is evidence that we might be able to use it as a predictive marker because patients with EZH2 mutations actually seem to preferentially benefit from CHOP or CVP, and the contrary was true for patients without the mutation, with wild-type EZH2, where they seem to have preferential benefit from bendamustine.
There's considerable heterogeneous in follicular lymphoma patients. About 80% of patients will do very well with standard immunochemotherapy. Remaining 20% unfortunately have early progression within 24 months. That we've identified that as a poor prognostic and long-term predictor of poor outcomes. Unfortunately, our current tools of risk stratifying patients are unable to identify patients at greatest risk for early progression. But it is certainly an active research question where we really need to predict and identify those patients at greatest risk, and ideally identify therapies that improve outcomes in that highest risk population. There's been a number of studies recently that are trying to identify the patients at greatest risk for early progression. The M7 FLIPI in patients treated with R-CHOP does seem to have some prognostic ability to identify a high-risk population. About 20% of patients have a high M7 FLIPI score, and in those patients, only 25% are without progression at 5 years. But that was a group treated with R-CHOP. In all comers, we unfortunately don't have the tool. We don't have the predictive tool right now to identify those patients at greatest risk. There was an abstract presented at this year's ASH looking at the T-cell component in the intrafollicular region of follicular lymphoma, and there was a signal that perhaps looking at CD4 staining may be able to improve upon FLIPI, but that work needs to be validated going forward.